The following is a production of Texas Lutheran University. For more information, please visit tlu.edu.
I want to welcome everyone to this afternoon's Biology Department Seminar. I'm Dr. Leevens, those who don't know me, and chair of the Department of Biology. And we do want to welcome you to this Biology Department Seminar today. Dr. Squires will be introducing our speaker today, so I will turn the floor over to him. So welcome.
The title of our talk today will be Under the Bleachers by Seymour Butts. It did work. I mean, John said it would work. Well, we're very privileged to have Laura's mom and dad here with us. So I'm going to introduce them. John is a graduate of 2002 of Texas Lutheran and a veteran of the United States Air Force. Thank you for your service. And it's my privilege to turn it over to Captain Cutie Pie's Good Girl Army. Laura.
I'm very honored today to introduce my mom, Dr. Julie Thompson. She's an adjunct professor at UIW's PT grad school and also works with the SCUC ISD school district helping students who have disabilities. She'll be talking about wound care today, and we'll also be answering questions about PT school and other questions related to the PT profession in general.
Thank you. Can we have the lights? Ah, good. Okay. I want you guys to read the fine print. Okay. You got that? All right. What'd you all have for lunch? We'll see you in a few minutes. Excellent. I love that attitude. It's going to be great. Okay. So we're going to talk about wound care, and let's go ahead and get started. And we always have to start with a little levity.
My joke didn't work, so.
I got a few more guffaws.
Nice.
Okay? And then for those of us that are getting on in years, there's still hope for us.
Okay.
That lady had a very good physical therapist, trust me. All right, so to talk about wound care, any kind of wound care, you have to have a basis in the skin. So the three layers of the skin are very important, the dermis, epidermis, and the subcutaneous. Which layers or layer regenerate? This is an interactive class. Okay, the others do or do not. Okay, so if they heal, then what do they come back as? Not scar tissue. What's the other word for it? All right, we'll come back to that one. Okay? Okay, types of wounds. Several different kinds. It's important to know what the wound is and what it started out as. You almost have to be, if you're going into physical therapy or a doctor or nurse or whatever you choose to do, you have to know where it started, why it started. You can't treat something for days and days and weeks without it healing up and not know why. So you need to know what started it, what are the characteristics of it, so that you know how to treat it properly. Decubitus ulcers or pressure wounds present in a very different manner than arterial or venous wounds, as well as diabetic ulcers, burns and surgical wounds, as well as the others. We won't talk much about the lacerations, puncture wounds, surgical wounds, and burns, just because we don't work with that a lot. I don't work with the burns. I haven't in years, but so it's going to be the first three that I work with the most. Any questions so far? By the way, if you have a question about the presentation, go ahead and ask it when you think about it. Otherwise, number one, you'll forget. Number two, there's probably 5, 10, maybe even 15 people that have the same question, okay? Sorry, that's the last of my jokes, promise. Okay, so basic goals of wound care. We want to protect the wound from further trauma, particularly if it's a pressure ulcer. What is a pressure ulcer? How does it start? What was the question? Bed sores. And what is that?
It's from laying on the surface of the skin
and causes a wound from what happens to the tissue between the bone and the bed? Yes, there we go. It dies. So, whoops. So you get necrotic tissue, okay? So since that is essentially trauma, you want to protect it from further trauma. You want to prevent infection. So you want to cover it, apply the right dressing, the right topical. You want to promote the wound healing. So we talked about the 3 layers of the skin. And do we want the wound to close over the top, or do we want the wound to heal up from the bottom? Heal up from the bottom, very good. And we want to promote the healthy formation of scar tissue or the other tissue that we're going to learn about in just a minute. And then, of course, prevention. We don't want it to happen again. I had a person in a nursing home who had a wound on their hip. I thought I knew what the issue was, but she had just gotten a brand new wheelchair, and we healed up the wound, put her in the brand new wheelchair, and it developed again. We thought it was pressure, we thought it was some other issue, but what we realized was the cushion in the chair was in the improper position. So when we put her into it, it wasn't comfortable for her, so she scooted her hips forward. And as she scooted forward, she rubbed the side of her hip on the wheelchair. So you have to be, as I said, rather forensic about it and figure out what's going on, why it started, what caused it, so that you know best how to heal it. Okay? There are stages of wounds. Stage 1 is a non-blanchable erythema. What's erythema? Mm-hmm. It's blood, it's red. It's redness on the skin, that's erythema, okay? That persists for greater than 30 minutes. Now, again, you have different colorations of skin, so you're going to have to be aware of that. That's going to have a little slightly different presentation than Caucasian skin, okay? So you have a stage 1. So if you have a red spot on somebody's skin, let me have your hand for a moment, please. So if I put my thumb on her bony area right here and I kept it there long enough, it would turn red. If I took it off and then I held it again for a second and it turned white, that's blanchable or non-blanchable. So that's how you would tell whether you have a stage 1 or not, okay? Again, those are the stages, stage 1, stage 2, stage 3, and stage 4. We'll go through each of those. The thing you also have to remember with a pressure wound is that our skin changes as we age, unfortunately. Nice, healthy, young tissue is very opaque. You don't see much through it. It's pretty tough. As we age, we lose the, what? Collagen and what else? Yes, ma'am. Elasticity, so it becomes a little less flexible. So things happen easier, and you're going to have breakdown. Is the epidermis or the dermis and the subcutaneous, which level of skin is more susceptible to pressure, more sensitive to pressure? I'm sorry? The dermis and the subcutaneous. So looking at these, and as you look at these pictures that I get to show later on, when you have the redness or the erythema on the skin, then you have what's called an iceberg effect underneath, because the epidermis will show less than the subcutaneous or the dermal layers, because it's much more sensitive to pressure. So it's best, it behooves everyone to prevent this in the early stages rather than let it get overwhelming. There's a stage 1, non-blanchable erythemic area. Those are not bruises. Bruises are a slightly different color. You'll see a picture of one later on. Okay? Stage 2, partial thickness. So that's gone through the epidermis, possibly into the dermis, but not as deep as into the subcutaneous. It presents as a blister or a very shallow crater. These can be created by pressure. You can also see them as friction or shearing? What's the difference between friction and shearing? Yes, ma'am. And so what's friction? Friction is if I took my finger and rubbed it on her epidermis, I would eventually probably create a blister. So it's like getting a brand new pair of shoes or hiking boots and going out and dancing all night or hiking up and down a mountain. Friction or shearing then is the opposite. It's what my brothers used to do to me, where they'd take my skin like this and twist in opposite directions. They thought that was lots of fun. I didn't. And a blister will present pretty symmetrical, round, fluid-filled sac. Shearing usually presents in more of a teardrop shape. Okay? There's a stage 2. When you look at wounds, you want to be able to describe what you see. In the world of physical therapy, nurses stage wounds. I'm sharing that with you so you know, but as a physical therapist, I don't stage wounds. Nurses must downstage wounds to show healing and progression. We're not allowed to do that. I don't know who decided that, but that's the rules. So we get to describe what we see. So can anybody tell me what you see in this wound bed? Tell me color, percentages, consistency. Think of that as 100%. Is that what you're calling this? The yellow? The white? Okay. It does look like a crater. Good. Okay. How about this tissue right here? Okay. All right, we'll learn that in just a second. Hold that thought. There's another picture. Some of them aren't as clear as they could be. I apologize for that, but there's still information that I want you guys to see. Just a little slightly different presentation. What's different about this one as opposed to the other one?
More superficial.
Not as deep, more superficial. What about color? Okay. Okay, we'll learn what those are in just a second. Good. Good descriptions. How about that one? Nobody getting sick yet? All right, just wait. You don't like that one? Really? It didn't look like the cheese on your lettuce salad. Oh, no, I'm just getting started. Okay, so what do you see? What do you see here? Redness, or what do we call that? Erythema, exactly. So you also, and that's a very good point, you want to describe the surrounding tissue as well. This outside area, this erythema here, that's going to be susceptible to breakdown. So you make sure that you describe what's going on the outer edges. This looks pretty involved. It's been there a little while. This is getting, does that look dry or moist? Dry. Okay. This is a little moister.
Are the darker colors like the dead skin, and do you remove that?
Yes, ma'am. Exactly. This is dead tissue, or what's another word for dead tissue? Necrotic tissue, absolutely. Now with necrotic tissue, we'll learn in just a moment, there are two types of necrotic tissue. So keep that in mind. What part of the body is that? Yes. Okay. So you have the heel, the foot, and then the ankle. What do you see here? Subcutaneous bleeding, bruise. It's a blister. You can't really see it as well from there, but it is a blister with some inside darkening that you would call bruising. That's trauma. So it was already probably a lot of pressure on it, and then it just continued to not be moved. So that will present as that very dark purple color. And this, I'm not sure, either a healing wound or another type of abrasion. Okay? And there is a blister that popped. That one popped. Okay? So, whoops, sorry about that. Okay. Stage 3, full thickness skin loss. down through the subcutaneous tissue, presents as a deep crater. Starting to get into the good stuff. All right? And there you have all 4 stages. You have stage 1, non-blanchable erythema, a grade 2, or a grade 3, which is a deeper crater, and then you have the stage 4. That's not my best picture, by the way. Okay? So again, you want to look at describing what you see. You have this nice red tissue here that we're going to learn the name of, and then you have some red tissue here. You have some of the other yellow stuff that you were talking about earlier, the wound edges and the surrounding tissue that you were talking about before. Yes, ma'am? Doesn't look completely normal because, again, only the epidermis regenerates as epidermal tissue. So the lower layers don't. And that's going to become very important. Okay?
And what are the pictures on the side next to the actual wound?
Those are hard to picture, but they're just, they are like drawings or somebody's rendition of what this looks like on a sagittal cut. Okay? So can pressure ulcers only happen on bony prominences? Apparently not. I had a lady go into the hospital, and granted she was kind of grumpy, but she came back with wounds all on one side of her face, her ear, her cheek, shoulder, elbow, ribs, hip, knee, ankle, and then on the insides of, so she was laying on her side the whole time. So they're predominantly over bony prominences because of what this young lady talked about, the tissue being pinched between the bone and whatever surface they're laying on. Even if it's a soft bed or a soft pillow, things can happen. It depends on comorbidities. What are comorbidities? Does anybody know?
Put me on the spot.
Comorbidities are other things going on. Diabetes, high blood pressure, other illnesses or sicknesses or disease processes that would impede circulation, hamper nutrition through the body, things like that. So comorbidities and things like that are going to affect how easily these things happen. Stage 4, full thickness. Can go all the way down through all the layers, joint capsule, tendon, into the bone. Does anybody know what happens if you get bone exposure to air? Yes, which is, do you know the name for that? A bone infection? Ah, very good. Osteomyelitis. If you know the answer, you're probably right, so speak up. It's okay. That very good. Osteomyelitis. Nasty stuff to have, very tough to treat. You have to have IV antibiotics. Okay? How's that one? Is that a good one? You like that one? What part of the body is that? Gluteus maximus. What's the bone that it's? Not quite. Part of the pelvis. Ischial tuberosity, yes. Ischial tuberosity. So the bones you're sitting on right now, that's what this person was sitting on. Much too long. So describe what you see. Oops, sorry about that. The erythema around the edges. It's tough to see in here, but that's another kind of necrotic tissue, a moist necrotic tissue. What would you think that stage would be? Likely. If you can't see the bottom of the wound of clean, viable tissue, the nurses will stage it as a stage 4. We call it it just went out of my head, but we can't stage it, so we don't know what it is if we can't see the bottom of it. So this one is probably a stage 4. You can probably guess that from what you see. All right? What part of the body is that? What do you think? That's probably, the ASIS is where his thumb is. You said it before. Sacrum? That's the sacrum? Okay. What kind of tissue is this? That's one of the necrotic tissues. Okay, remember I said there's two types of necrotic tissue. We're going to learn those names in just a second. Okay, wound characteristics and tissue types, necrotic tissues. Actually, there's three kinds. I talk mostly about the first two. Hopefully you don't see the third one too often. So, necrotic tissue, there's eschar and there's slough. All right. Does anybody in here like beef jerky? All right. Eschar looks like beef jerky. You're welcome. You'll never forget this lecture. Eschar is usually light to dark brown, very dry, looks just like beef jerky. So next time you go eat it, you'll think of me. You're welcome. Oh. All right. How many in here like pizza or had pizza for lunch?
Don't raise your hand.
I'm going to tell you anyway. Slough can be anywhere from light yellow to brown to blue to green. And it looks like the melted cheese on your pizza. Right? So next time you have a pizza again, you'll think of me. That's that yellow slough. Now the trauma is a dark purple area like you saw on that heel, but I'll show you an even better picture. Okay? Abnormal tissue. These are things that can happen to wounds that you don't want to happen. Induration. Induration is a very hard, not like the eschar, but it's a very hard, like a keloid scar almost, kind of raised and hard, but the color of tissue. Epobole, you'll see that it's around the edges where the wound has not healed properly. The epithelial tissue is really trying to migrate across the moist wound bed, but it can't, so it curls under itself, and there's rolls around the edge of the wound. And that will tell you that that wound is chronic, that it's been open quite some time and hasn't been able to heal. Hypergranulation, oh, I just gave you the answer. When you have a wound, remember we said that the subcutaneous and the dermal tissue don't regenerate. What they come back as is granulation tissue. That would be a good test question. Granulation tissue. So granulation tissue, you want to have a clean wound bed. The granulation tissue will grow from the bottom up. When it meets the edges of the wound, then that epithelial tissue can then migrate across that clean granulation tissue. You have to have the right temperature though. If it's too warm, you'll get bio buildup, abnormal bio buildup. If it's too cold, it won't heal. You want it body temperature, give or take 98.6. Okay, that's why we don't leave wounds open. That's why we don't leave them with wet dressings for too long. Okay, so hypergranulation, what happens is that the body just went, let's just make this happen, and the granulation tissue just keeps growing, and you get this mound of granulation tissue. Okay, maceration, if you happen to stay in a hot tub, swimming pool, shower, or bath too long and your skin gets all wrinkly, that's what happens. You're not managing the exudate or the drainage of a wound, and you'll get white around the edges. So you'll see some pictures of that. Any questions so far? Okay. What is that? Eschar, beef jerky. See, did I lie? Looks like beef jerky. What part of the body is that? The heel. All right, I want you to pay close attention to the edges of this wound. What do you see? You might see that from this picture. It's not real clear, but is the eschar connected to the edges of the wound? It's raised a little bit, but look at the edges. Are they connected or not connected, I guess, is what a better question is. No? All right, let's show you another picture and then you tell me. How about that one? Yeah.
How does this come about forming? Just people not caring for these wounds whatsoever?
That's a really good question. You're going to sit in these chairs for an hour. But what you guys are going to do is you're going to move around. You're going to shift your weight. You're going to lean forward. You're going to lean back. You're going to shift your weight, which keeps the blood circulating to that tissue between the chair and your bone. For these people, what has happened is they've gone through surgery. They don't feel well. They got pneumonia, whatever, and they're not moving. So it takes them longer to move around, to realize they might have decreased sensation, they just don't feel good, so they stay in one position longer. So hold on to your question, the circulation will decrease to that area. Now, for you and I, it takes a lot longer. Half hour, an hour, 2 hours, sometimes you can sit without moving and not have a problem. We have good blood circulation, we have good nutrition. Some of these folks, when you don't feel well or you're older, the nutrition in your blood is very poor. Number one, you don't have very good sensation, so you don't know it hurts, you don't know to move, and it doesn't take as long then for that skin to break down because the skin is thinner. Okay? So they may have been sitting only for a half an hour to have something happen like this. It doesn't take very long. Now this one took a little bit longer, but in some of those instances it doesn't take long. That answer your question?
About how long does it take to go from stage 1 to stage 2 to stage 3 to stage 4?
Again, it depends on nutrition, circulation, how much feeling they have, how well health professionals are at relieving the pressure. Once you notice either the red spot or the crater, to cover it, use the right topicals, the right treatment approaches, get them walking and exercising again.
Well, I mean, are we talking about like this all happens within a day, or does it take a week or so of sitting in the same spot or sitting there continuously for,
I have seen things go from relatively okay to very bad overnight. I'll show you a picture of what one looked like. Just overnight, they forgot to turn the air bed on at night. I got there at 10 in the morning and the wound looked like one of them. I'll show you. When it was looking like it was going to heal, probably a stage 2, it had gone back to a stage 4. So when people are compromised, it doesn't take long at all. Okay, yeah?
Why is it not standard protocol when people are bedridden to put them on an air bed? You know, I've seen them after they start developing ulcers, then they do it, and it seems like it's so much more cost effective to do it immediately. I mean, they only cost $20, you know, and then, and I think it should be part of almost any nursing home surgery protocol to just immediately do that.
You'd think so, but you're trying to apply logic and reason to systems that are not logical or reasonable all the time. And it does boil down to dinero, the initial cost of a bed. Even though you may think it's only $20, it has medical on it, so it's probably $200 or $300.
I mean, I've purchased 3 of them, and it's $20.
I don't know. Why would they let a wound go on for months and months and years when I can heal it in 6 weeks or 3 months? I don't have a good answer for you. They should be on a good turning schedule. They should be on a good changing schedule. They should be out of bed. Like I said, trying to apply logic and reason to sometimes a illogical, unreasonable system. I don't have a good answer for you. They do, some beds, some air mattresses or pressure relieving mattresses are difficult for some people to get out of. So it's, do we want them out of bed, or like air beds, or some of the sand beds that they have in the hospitals? Those are difficult to get out of. So do we want them? Do we just want to put them on a turning schedule in a relatively not so hot mattress, or do we want to put them on an air mattress and make it difficult to get up? There's a lot of questions you have to ask when you have that presentation. So between this one and the last one, is this a wound you want to address or no? For me, I would cover that and leave it alone. The reason is because the edges are connected to good, healthy, viable tissue. There's little to no chance that Any nastiness is going to get underneath that. God made a beautiful system where if that stays intact, it will heal up from the bottom. That will become lighter and peel off and fall off, and you'll have skin under there as nice as a baby's bottom. Okay? But this one you have to deal with because it's now open to air and potential infection, which you can already see. So that one you do have to deal with. I would. Some people that are less experienced probably wouldn't because you have to make sure that they are not on blood thinners, have diabetes, have peripheral vascular disease, things like that. How's that one? That's a good one, isn't it? Is that cheese pizza slough? With that one, I would take my tweezers and my scalpel, and I would pick up that cheesy pizza and debride it and take it off because that wound's not going to heal with that on there. You need the good, healthy, vial. Yeah, go ahead.
Does it smell bad?
Yes.
Thanks, Rachel.
When? I love that question. It was funny
When
because
things get infected and stuff, they smell bad. So
you are going to have an odor anyway because, again, God made a good system that is autolytic debridement. That's when the body is debriding itself. That's the natural process that you learned in biology, the macrophages and all of those. Your body is eating up the dead tissue as much as it can, so that's going to cause an odor. Now, if you clean it and there's still an odor, you run the risk of it probably being infected. And once you smell an infected wound, you'll always smell it, won't you, honey? It's a very distinctive odor. I was preparing this for my other class and for this class, and my youngest daughter was walking by going, "Oh, Mom, that's so gross." And John pipes in from the background. He goes, "Yeah, the only time she'll be happier is if somehow she can make it smell like it." I would be. I think that'd be so cool. You got to get the. That's it. Or have a candle. I could have a candle burning.
aerosol isn't good for the environment, Squires.
You bet. Your sense of smell will just wake you up.
Yep.
I went to visit her once when she was working on a wound at this level, and I'll never forget that smell.
It's a very pungent, earthy smell that really you won't forget. Really? So what do you see here? You see the slough, the yellow slough. You also see those little red buds there. Those are skin buds coming through. So there is some healing going on here. What is this here? That is also an area that has been healing up. Okay, so that already had a wound, and it's been remodeled. I guess I better speed up a little bit. This is the wound that I thought was healing up pretty nicely. They were very proud of what they'd done with her. We rolled her over, uncovered it, and it looked like this. And I looked at the bed, and the air mattress was down. I said, "Really, guys, when did you turn the mattress off?" "Oh, I don't know." And another CNA came in and said, "Oh, I didn't remember it being turned on at 6 when I came in this morning, so it had been off since last night." This is what happened. That dark purpley tissue, that's trauma. So that very sensitive granulation tissue that was filling in now has been re-traumatized. We've set this healing process back probably 6 weeks, 6 to 12 weeks, just by letting that happen. There's your hypergranulation, where the body went overboard. Went, OMG, we better heal this up. All of that is hypergranulation. There's a good, healthy, healing wound. This is what you want your granulation tissue to look like. Looks like nice, fresh ground beef. The texture. But that's what you want it to look like. A very nice texture, not flat, not pale pink, bright red texture, granulation tissue. Oh, sorry. This around this edge, that's that maceration. That is a highly draining wound that's not being managed. This tissue runs the risk of breaking down if we don't manage the drainage, the exudate. Okay? There's another one. This is that epobole I was telling you about. It's very hard, indurated around the edges. That wound has been trying to heal for a long time, but it hasn't been able to because of all the slough in there. I'm not sure what body part that is. Some people thought it might be back of a knee. Whoops. It could. It's hard for me to tell. Okay, for physical therapy, we go through the phases of healing. Okay, inflammatory phase now. We talked about an infected wound. What are the normal stages of a normal healing wound? You get erythema, redness. You get drainage, you get pain, and you get warmth. What are the symptoms of an infected wound? Oh, redness, drainage, pain, and warmth. How do you know whether it's infected? Smell. Absolutely, the smell. Do not tell Emily that answer. Okay? So, and also you can get a culture. Hard to do in the nursing home. A lot of people don't care for that. A lot of doctors won't order it because most wounds are colonized because we don't live in a sterile world. But if you do get a culture and it's greater than 100,000 organisms per gram of tissue, it's infected. This stage lasts 4 to 7 days in a healthy person. Okay? Okay, you can have, wounds have to go through those 3 phases of healing, but you can have several phases going on in one wound. You have your granulation, your proliferation phase, you have your remodeling phase, but you also still have your inflammatory phase going on. Same thing. You have some eschar, you have some granulation buds, some skin buds coming through. You still have an inflammatory phase. This is kind of a chronic one. You've got a lot of erythema going around the edges. Chronic inflammatory phase again, because you see the red around the edges. You've still got a lot of yellow slough, although you do have some ground beef growing through there. Okay? You have some eschar, you have some slough. This is a little drier wound, but you've got a lot of erythema. This is where the tissue underneath has just stuck. It's just real tight. It's adhered to the bone and the tissue below it. That one, I tried to clear that up as best I could. This is actually tendon or fascia. It will come up as a very white, shiny looking material. This is, healing, remodeling. You've still got inflammatory phase, and this is not healthy. This is a pale red, very flat. That's not healing well. Same thing. You got a lot of different phases going on, but again, you can see that this poor person has had a lot of things going on. That's not even my best one.
I'm not getting queasy.
Okay. Okay, proliferation phase, establishment of collagen matrix, growth of granulation tissue, epithelial cells may migrate across the warm, moist wound bed. That's 4 to 21 days in a normal, healthy person. Okay. There is a good picture of it. Even though you still have this one little spot, you've got some nice beefy red granulation tissue. You've got some edges that are fairly flat that are ready to migrate. You do have a little dark area here that might be what's called undermining, where you've got the skin and you may have a little bit of granulation area that needs to fill in here. Okay, is that one healthy? No. Not bad, but it's not healthy. That's in a chronic proliferative phase. It's red, nice beefy red, but it's very flat and it's draining, highly draining, and you've still got some slough going on in there. See how different those wound edges look in a darker skin than in the lighter skin? You have to look very closely for those changes. Did you have a question?
How do you know what stage or what type of wounds to use wound vacs on? Is it just ones that have like a lot of slough or drainage, I mean?
Wound vacs are a treatment approach where it's basically like a vacuum, and they create a negative pressure field where there's another machine that pulls the drainage out of the wound. Very, very effective treatment approach. It's not a skilled surface. I don't apply it. The nurses are able to do that. But they use it on deep wounds. They use it on difficult wounds to heal. Any wound that is taking a while to heal, that really has poor circulation, that we really want to try, because it'll pull the blood supply in from quite a distance away. So wound vacs are very effective treatments. Good question. Okay, kind of a chronic wound again. Lots of erythema around the edges. You still have some of the eschar going on. I guess I better speed up a little bit. Okay. Nice beefy red. The edges don't look too bad. You could start down here seeing some migration. Okay. This is too macerated. It's still too deep, and you've got some stuff going on in the depth that needs to be cleared up before you can progress it. This one is trying to close up, but you've still got some holes in here that need to fill in. Healing nicely or no? No. Those are kind of chronic. You can see the dryness around the edges. They've tried to heal areas, or this area of the foot has really poor circulation. Tough to get enough blood supply there to heal it up. So you have to be careful, especially if you add diabetes or any other comorbidities on top of that.
Can I just comment that?
Yeah.
Go back to that one foot slide. You guys are tired of hearing me. My little artery in the class, the atherosclerotic artery, the long extension of atherogenesis in peripheral vessels. The vessel dies off, lack of blood flow, and then we have a peripheral neuropathy. Then the nerve goes, and then they don't feel the pain, and then they get this. And that's going to be your challenge. 50% of everybody that you're going to see, you're going to have some manifestation of atherosclerotic peripheral vascular disease.
Mm-hmm. Yes.
How do you increase the blood circulation? What do you do to increase the blood circulation?
Mm-hmm. It's not just increasing the blood circulation, which as a physical therapist, we do a lot of exercises, lower extremity exercises, ankle pumps, ankle circles, alphabet, writing your name, things like that, walking also. But you have to make sure that the blood that's getting there is of good quality as well. So you have to be very careful of the lab reports. Make sure that they've got enough vitamin C, zinc. You might even extra supplement those unless they have a kidney issue. But you have to make sure that the blood that's getting there is as good as it can be to help heal up that wound. Okay?
Do you use hydrotherapy or barometric chambers?
Barometric chambers are excellent way to heal wounds. Unfortunately, nursing homes are under money constraints, and unless they have to, they don't send them out if we can heal it up otherwise, even though it's a very valuable tool. We used to do whirlpools a lot when I started out 30 years ago, was BID, betadine whirlpools, twice a day whirlpools with betadine in it. Well, betadine is cytotoxic to normal healthy tissue, so we don't do that anymore. And actually, the whirlpools, they've done cultures, they've cleaned them, they've done whatever they can, and there's really still some culture nasty enough in the pipes and in the turbines that run the whirlpools, so we try not to do hydrotherapy as much anymore, just use normal saline to clean them.
And correct me if I'm wrong, she mentioned comorbidities. The problem with hyperbaric therapy is we put a person in a chamber is that a comorbidity, they'll have retinopathies in the eyes, and so the diabetes will affect the eyes, and so you put them in a chamber and you start bursting eye vessels, and then we lose vision. So therapists are reticent if they have a bunch of comorbidities of using the hyperbaric chamber.
You always have to look at the precautions and contraindications to whatever treatment you choose. Yeah?
What does PT stand for? PT?
Sorry, physical therapist, doctor of physical therapy. I have a doctor of physical therapy. Okay? This person was sitting way too long, but it is some good beefy granulation tissue, but they're not managing the drainage. And it's been there a while, you can tell by the stuck tissue. I like that one. Yeah, that might, whoops, I'm sorry. That might be. Down here, Laura's thinking that might be the femur, it very well could be. If you're treating a wound and you use a Q-tip to go in, and you can't really tell the bottom, but if you use a Q-tip, the bone feels like sandpaper. It's a very different feel from normal healthy tissue or even necrotic tissue. It feels like sandpaper. Okay, the epithelial phase or remodeling phase. Okay, organization of scar tissue. It's initially red because of the capillaries there and the angiogenesis. It decreases. That's why you saw some of those healed areas as whitish, because then the capillaries have receded again. You shouldn't let them go out into the sunlight for up to 2 years. It takes up to 2 years for this to completely heal up. The one thing I want to mention about, because it doesn't regenerate as dermal or subcutaneous tissue, it regenerates as granulation tissue. It's only ever about 80% of its original tensile strength. So it's never completely normal. Okay? There's kind of, it's not real clear, but kind of shows the progression. Again, kind of a progression of this deep, I think that's a heel, to contracting and healing up. And there's one that's remodeling nicely. Again, you see the white area here, and this is really closing in nicely. Very good example. And there's remodeled. Kind of looks like a stage 1, except a stage 1 is very erythematic. This is paler.
So will it always be pink like that?
No, then the capillaries will recede and it'll turn white like some of the other scar tissue. Good clarification. Okay? Until the pigmentation grows back. Skin graft healing, you deal with skin grafts quite a bit. Okay, I'm going to run quickly through because again, this was an 8-hour course. I tried to squeeze into 50 minutes, so I'm going to run through this.
We'll give the 8-hour test, though.
Yeah, I'll be happy to come and get it. Okay. Just know that arterial wounds will present very different from venous wounds. Arterial wounds, the blood supply isn't getting down to the extremity. Very different punched out appearance. They're deep, don't drain very much, but they're very painful. And they're around and on the toes, phalangeal heads and lateral, what's that word? See, I say malleolus. Didn't you learn anything? Malleolus? Yeah, I call that the malleolus. That's what maybe we say that up north, not down south. Joyzy. Okay, so rather punched out appearance, okay? Okay, arterial. Uh-oh. That one didn't heal very well. Okay. That actually, they call that gangrene now. That has gone into gangrene. Probably will lose those toes. The thing I want you to see here is this. That will give you an indication that the blood supply is compromised. Probably not going to be able to save that foot. Okay, kind of a cookie cutter punched out. I guess for you guys more biscuit than cookie cutter. Always have to relate it back to food. Venous wounds. Okay, so the difference between the artery, the blood isn't getting down there. With the veins, what happens is the valves are compromised. So instead of the blood being pushed up into a chamber and the valve closing, they stay open, the blood doesn't move back. So you get a lot of swelling, irregular edges, a lot of drainage because you've got usually a lot of swelling, but not usually very painful. That's why they're poor compliance with these kind of people. Okay, you see this has been here a long time, but they were able to heal it up.
Is that why it's so purple?
Mhm. And yeah, this is that indurated skin. That swelling has been there a very long time. That tissue gets very tough and fibrous. Kind of like the beef jerky, but not quite the same color. Person not very compliant with keeping their legs up. Okay. Highly exudating. That one has a lot of biodebris component. I can't tell you how often I see that. And I have to actually tell the families to get different socks. Okay? Now, here's that indurated skin. Okay?
Are they going to lose that foot? Why is the toe so yellow?
Poor circulation. Very poor circulation.
Atherosclerosis.
That's it. Okay? These are the tortuous veins, venous insufficiency. You'll see that a lot. Irregular edges. Okay? I tried to make that one smaller so it was a little clearer. Those may not be salvageable. I wouldn't. It's out of my scope of practice. But if any of you are going to go be doctors, you might. Sure. Huh? 2-minute warning. Okay, I got to go a little faster. Diabetic ulcers, just like Dr. Squires was talking about, even well-defined margins, variable depth. With these guys, because of their lack of sensation, this was probably a small pebble in their shoe or even a folded piece of sock that they couldn't feel. I visited a guy in the nursing home. The CNA said, come look at his feet. His toes were all curled up. It was red all along. He was wearing a size 8 shoe, and he actually should have been wearing a size 9.5, and he couldn't feel it. Okay? That's callus formation around there. Diabetic foot ulcers. This is what happens because of the atherosclerosis. I can't say it. What he said. The arches fall, everything falls down. It doesn't, the feet flatten out, and then you start getting bone on bone and bone on shoe. That's probably one that started out as a little teeny tiny pebble in the shoe. Very hard to heal because of the callus formation around them. Okay, just the things we take into account when we talk about what's going to affect the healing. All of those lab reports, all of that, nutrition, how I assess a wound, we won't get into that. They're trying to figure out the depth of that wound. Drainage, don't get caught up on what it's called, describe it. Thin, thick, watery, opaque, and again, the color. Consistency, okay? That's a lot of drainage. That as well as a lot of drainage. There's a lot of different kinds of dressings. I have some examples here if you want to look later. Topicals, Accuzyme, Panafil, Santil, those are all granulation stimulators or autolytic, not autolytic, but helping to debride. There are also other ones. Xenoderm will help with epithelialization, just a lot of different things you can use. Don't get stuck in a hole. Treatment goals. Okay, that's what you want to do. And then some of the treatments that we use, we've kind of already talked about. Not so hot on laser, wet to dry, because wet to dry takes everything with it, the good and the bad. So we're a little more selective. There's a wound vac. That's what that looks like. Yes, ma'am. Leeches. Okay. My youngest daughter walked by when that was up, and she goes, "Oh, Mom, that's so gross." I go, "That's not gross. That's gross." Isn't that awesome? I don't do that. That's more doctors do that. Do you guys have any questions for me? You had one. Then you, just a second. Yeah?
Do you go about healing things differently in sense of how the scar is going to turn out? Like, I'm trying to think of a way to explain better what I mean.
You want to know what the wound is, what caused it. You're going to choose your dressings and your topicals based on that information. So yes, you're going to approach wounds differently, and what you used yesterday may not work today. So that's why wounds are so exciting for me, because it changes from day to day. I could probably eat a sandwich and do wound care at the same time, but that's just me. I could eat pizza and do wound care at the same time. She had a question, and then you. Yeah?
My grandfather had always told me that if you rub a wound, it'll heal a little bit faster. I can see like
The logic in that?
the logic in it because it would pull blood faster to the surface, but how do you think that would affect it?
With these kinds of wounds particularly, and most wounds in general, that tissue's compromised, so you don't want to rub over the top of it. Now, we use things like diathermy on the femoral artery that will increase the blood flow to the lower leg, to increase that blood flow to help heal it from there. You can do some massage distal to the wound itself, not over the top. But there is some logic in that, absolutely. Yeah?
Emily had told me to ask about how you pack these wounds in to enjoy the pictures.
Emily is going to get in trouble because I can't answer questions at my other,
This was just probably to gross me out.
probably. Yeah, she said to enjoy the pictures. They really got grossed out. You guys are pretty calm. I'm impressed. I can show that after class if you want, how to pack a wound. I can be here for a little bit. Yeah?
Is pain management up to the doctor, or do you kind of deal with pain management for these types of things?
Absolutely. The doctor has to order the pain meds. I can't, but we're the first line of defense, and we should not treat a wound that's in a lot of pain. You saw in one of those lists, lidocaine. I will use a topical lidocaine, let that sit for 5 minutes or so, and then do my sharp debridement, especially if they're in a lot of pain. But I can advise the doctor on, I think this person really needs to be pre-medicated, otherwise I'm not going to be able to get to that wound. So absolutely, pain is a huge deal, especially in the nursing home.
What percent of your practice is wound care?
It's gotten less over the years because Medicare in their ultimate wisdom didn't think that that's very effective, so their reimbursement is poor, so nursing homes don't want to pay for it. But
Normal physical therapist, what percent would be wound care?
Depending on the setting, if you're in the hospital, it would probably be higher, anywhere from 30 to, if you really like it, maybe 60%. In the nursing home, it's gotten less. They like to use wound treatment nurses rather than therapists, so maybe 25%.
How many people before this talk understood what an important part of physical therapy was? It's not about sports physical therapy, about the Tommy John thing, but this is in the basic stuff. So if you want to be a physical therapist, you have to deal with this stuff every day. So that's why I really, really wanted, when she said wound care, I said, boom.
And actually, that's a good point. It's more about the prevention of it, because to relieve pressure and take away a stage 1 costs a whole lot less than trying to deal with the one with the sacrum and the ischial tuberosity. It takes a lot longer, a lot more expensive material, a lot more manpower. So prevention is the best idea. And really, with physical therapy, you can do anything from prenatal, newborn babies, all the way up to geriatrics, which is what I like to do. You can do cardiac, you can do hospital, you can do nursing home, you can do school district, you can do home health. There are so many different areas that you can work in physical therapy. And again, that's why it's so exciting. I have done almost everything in my 31 years, from work hardening to everything, so you don't have to limit yourself.
Further questions? We'll ask the good professor to stay afterwards down here if individuals want to talk. Dr. Levin's class is going to go over here. Did you want to say something quick about the pre-professional? Not right now? Okay. So thank you very much.
You're welcome.
Students at TLU engage in high-impact educational experiences that include civic engagement, aesthetic expression, critical thinking, and a focus on intercultural knowledge in a community that welcomes the interplay of faith and reason.